Right, that's a depth of responsibility I bear gladly. So, what I'm going to talk about this morning, as Anita said, is type 1 mitral regurgitation. And I'm going to preface the talk by saying that whilst I'm going to talk about what everybody understands, I think, as type 1 mitral regurgitation, I'm not going to call it that, and I'll come on to why in just a moment. And I'm sure you'll all be familiar with the conventional Carpentier classification of the mechanisms of MR into type 1 normal leaflet motion, type 2 excessive, and type 3 restricted motion, which we're going to hear about a little bit later on this morning, and the accompanying appearance of the valve schematically. Now, I think there are a few important things to cover initially about type 1 mitral regurgitation, and these relate to the definition. So let me just tell you what I'm not going to talk about. So covered within the classical Carpentier definition of type 1 are anything where the leaflet motion is normal but there is MR. So that would include defects in a leaflet related usually to endocarditis, can be congenital. I'm not going to talk about those because although they are type 1, they are a particular subset. What I'm going to concentrate on is the relationship between the annulus, the left atrium, and the ventricle, and why that can lead to significant mitral regurgitation with normal leaflet motion. Now, the fact that you don't have tethering of the leaflets in type 1 MR implies that the relationship between the mitral leaflets, the mitral annulus, and the ventricle is essentially normal. There is no tension placed, or no significant tension placed primarily on the papillary muscles and the cords by ventricular remodeling. Because if you have that and you have traction on the leaflets, that's type 3. So what I'm going to concentrate on is mitral regurgitation primarily related to abnormalities of the mitral annulus. And I think this is important in terms of understanding the mechanism and understanding the correction. And what I would like to suggest is that an alternative name for this type of mitral regurgitation is actually atrial mitral regurgitation, and I hope to be able to convince you about that over the next 15 minutes or so. So here's an extreme example, kindly donated to me yesterday by Anita, of an individual who has a relatively normal left ventricle, seems to contract quite well, slightly jerky loop, but with an enormous left atrium. Are these projecting okay, by the way, or do the lights need to come down? They're okay. All right. And there is a central jet of mitral regurgitation. If you look at this rather slightly off-axis, short-axis commissural view, there is a substantial amount of regurgitation. So this individual has a massive left atrium, marked dilation of the mitral annulus, and severe mitral regurgitation with a normal ventricle, and there is, or near normal ventricle, without any tethering. So this is type 1 mitral regurgitation related to abnormalities, probably primarily of the left atrium, and secondarily as a result of that, of the mitral annulus, but not of the ventricular myocardium. So this is what I'm going to be talking about. This is an extreme example, but nonetheless a good example of how this pathology can progress. So, again, as you'll all be aware, the mitral annulus and the mitral leaflets are a complex three-dimensional geometric structure, and it's important to bear this in mind when we're talking about the mechanisms of MR, both type 1 and also type 3, which we'll hear about later on. So there is, in terms of the three-dimensional structure, the annulus has a height to it, which is, yeah, that's great, thanks, which is maximal here, somewhere between the anterolateral and the medial commissures, more or less in the middle of the closure line of the valve. And you can make a series of measurements. You can measure the height of the annulus, you can measure the intercommissural distance, and you can measure the anteroposterior dimension of the annulus within 3 dimensions. And many of you will have experience of doing this with echocardiography. And I'm going to concentrate over the next few slides on the 3-dimensional analysis of the mitral annulus and the leaflets in type 1 mitral regurgitation. In doing so, I think it's important to recognise that this structure isn't serendipitous, it serves a purpose. And if you look at this relationship, I'll just go back to the previous slide, but if you look at this relationship between the height of the annulus and the intercommissural or anteroposterior distance, it serves a specific purpose, and the ratio of annular height to intercommissural width is related to the peak leaflet stress. So what this means in practice is if you lose that three-dimensional height of the annulus, if you lose it and it becomes flattened for any reason, either in type 1 or type 3 mitral regurgitation, peak leaflet stress is increased and the function of the valve is adversely impacted. So three-dimensional shape is important for the maintenance of normal mitral valve function. So the next couple of slides I'm going to show are taken from what I think is a very good paper published last year in the European Journal of Cardiovascular Imaging by Bushra Rana's group from Papworth. And they performed three-dimensional analysis of mitral valve anatomy, mitral annulus and leaflet anatomy, on a couple of groups of patients and some normal controls. And I'll go through those in a moment. But just to demonstrate what you can analyse using advanced 3D analysis software. This is the Philips one, but other versions are available. You can measure, this is the intercommissural distance, this is the anteroposterior dimension on that three-dimensional structure of the valve. You can measure the height of the annulus. You can measure leaflet. You can measure the area of the annulus. You can measure total leaflet area. You can measure the tenting volume of the valve, and you can measure various ratios of these. So you can get, using 3D reconstruction, you can get a detailed three-dimensional picture, three-dimensional image of the valve and an understanding of why it leaks. So on to the patients that they studied, because this is important. So they looked at controls. They looked at a number of individuals who they called atrial mitral regurgitation, essentially type 1 mitral regurgitation with normal valve motion, normal left ventricular function and volumes, and they compared these with a group of functional mitral regurgitation, ischemic mitral regurgitation, predominantly with a substantial degree of ventricular abnormality and ventricular remodeling. And what this showed, not surprisingly, is you get difference between controls and the type 1 and the other functional mitral regurgitation. I can't actually see this particularly well, so I'm going to move over here a little bit. And the differences between the two groups of mitral regurgitation here, between the atrial mitral regurgitation and functional mitral regurgitation, relate to left ventricular remodeling. So the ventricles in this group are bigger, more remodeled than in this group. There is no difference in atrial volumes. But what is particularly interesting is when you look at the parameters of the mitral annulus and the valve. So if you look at the change in the area of the mitral annulus. The mitral annulus, as you all know, is a dynamic structure. It contracts, it relaxes during systole and diastole. It is not passive. And if you look at the change in annular area is again a broad measure of the function of the mitral valve. This is the change in annular area in controls. These are the two groups. So this is type 1 mitral regurgitation with normal left ventricle, normal mitral leaflet motion, functional mitral regurgitation with a remodeled ventricle tethering of the leaflets. The impact on the annular motion is the same. Similarly, coaptation index, so roughly the proportion, the percentage of the area of the mitral valve, of the leaflets that actually coapt with each other, again, much higher in normals than in either of these two groups of mitral regurgitation. There is no difference in the degree of coaptation between the type 1 mitral regurgitation and the remodeled left ventricle of the type 3 restricted motion left ventricle. So the impact on the annulus and on coaptation are the same. But then if you look at the parameters of the leaflets, again, these are annular parameters. The parameters of the mitral annulus are the same in the type 1 atrial mitral regurgitation as with the functional mitral regurgitation. But the leaflet parameters, there are some significant and important differences. The tenting height of the leaflets between the AMR and the functional mitral regurgitation very substantially different, and the tenting volume also substantially different. So you would expect this with the remodeled ventricle. You don't get it with the type 1 or atrial mitral regurgitation. And the reason for this and the mechanism of type 1 mitral regurgitation is very well demonstrated in this next slide, which shows the three-dimensional reconstructions of the surface of the mitral valve in these two groups of patients. So this is type 3 mitral regurgitation, functional mitral regurgitation. There is restriction of the leaflets in systole. You can see they are tented down into the ventricle. This is the tenting volume. There's the plane of the annulus. Now, in type 1 mitral regurgitation, what they're calling atrial mitral regurgitation, here's the plane of the annulus, and here is the plane of the coaptation point as compared to here. And you can see the surface nature of these two mitral valves is very different. So although the end result, in terms of the degree of regurgitation, is the same, the size of the annulus is the same, the size of the atrium is the same, the way that you get to that point is different. Here, the primary cause is a ventricular abnormality. Here, a primary cause is dilation of the annulus. You get dilation of the annulus here, secondary to the ventricular abnormality. The problem here is a primary abnormality of dilation of the annulus, and that is the difference between these two conditions. So that's one set of evidence. So what about more evidence that this is the case? So I'm going to deviate away from TOE. Now I have to say I know next to nothing about cardiac CT, other than we have a very, very enthusiastic German colleague who's just got a new cardiac CT scanner, and he's a boy with a new train set, essentially. But there is some confirmatory evidence using cardiac CT that this description of the mechanism from that Papworth paper is correct. So this is from Leiden, and these guys took a whole bunch of patients coming through with atrial fibrillation who were being lined up for AF ablation, which is why they're getting the CTs, and they also had echocardiography to look at the extent of their mitral regurgitation. And using CT as a tomographic technique, you can again measure the mitral annulus, you can measure the intercommissural and anteroposterior dimensions, perhaps not as accurately as you can in terms of the three-dimensional anatomy with 3D TOE, but the voxel size is substantially smaller with CT than it is with 3D echo, so in that extent it's a more accurate measurement. And they looked at the extent of MR in these patients. And they also measured the size of the left atrium in three different planes. So they have a volumetric assessment of the left atrium. And what they did was to divide these individuals up, who all had normal ventricles, they were all in AF, they were all coming through for ablation, and they all had normal leaflet morphology, and they looked at those who had less than 2/4 mitral regurgitation and greater than 2/4 degrees of mitral regurgitation. There is no difference in the left ventricular parameters in these individuals. What determines the severity of the MR in these individuals is are the annular parameters. So intercommissural diameter, anteroposterior diameter, annular diameter. The bigger your annulus, the worse the degree of mitral regurgitation. So the degree of MR in these people with AF is driven primarily by annular size. Now, of course, it may be that it is the dilation of the left atrium, which is also substantially different in in those with greater degrees of MR, that is driving the dilation of the annulus. So annular dilation is secondary to overall dilation of the left atrium. And AF does appear to be quite important in terms of the mechanism of type 1 mitral regurgitation. And I hope to convince you of that from this data from another paper published a couple of years ago, again, looking at patients coming through for AF ablation, normal ventricles, dividing them up into mild or no MR, and moderate or greater degrees of MR, and then comparing them in terms of the parameters of their valves. And what you see is that the independent predictors of the extent of mitral regurgitation in these people, not surprisingly, there's age, there's hypertension, there's the persistence of the AF, all of which you would expect. Left atrial volume index isn't particularly convincing in this, but annular dimension, again, is key. So dilation of the annulus it appears to be the most important predictor of the extent of atrial fibrillation in these people with mitral regurgitation. And it's not just the AF may have an important mechanistic role in this. So the maintenance of sinus rhythm might be quite important. So this is taking that same group of patients with AF and looking at them pre-ablation and post-ablation. And if you look at those individuals who eventually had permanent restoration of sinus rhythm, and those who recurred AF, pre-procedure, there's precious little difference in the degree of mitral regurgitations. This is trace or none, this is moderate, between these two groups. If you then look at them post-ablation, those who had recurrence and those who stayed in sinus rhythm, those who stayed in sinus rhythm had a lot less mitral regurgitation than those whose AF recurred. Now, there's a chicken and egg issue here, but it does suggest that if you get people from AF back into sinus rhythm, there is the potential for plasticity, for remodeling of the annulus, remodeling of the atrium, and a reduction in the degree of mitral regurgitation. So in terms of the therapeutic approach to these individuals, maintenance of sinus rhythm may well be very important, or restoration of sinus rhythm may be very important. This seems to have frozen. Oh, okay. It's. I'll go back. It may be that it's just a little unwilling to play these loops. Try again. Okay. So there will be a lot at this meeting, I'm sure, about percutaneous approaches to mitral regurgitation. And this, as I'm sure you'll recognise, is the use of MitraClip in a patient with type 1 mitral regurgitation, where it can be used successfully. But the point I want to make about this is that the use of MitraClip in this way has provided a window into looking at the plasticity of the mitral annulus in patients with type 1 mitral regurgitation. So, briefly, this is the, on this panel here, this is annular size in patients with degenerative mitral regurgitation, pre and post MitraClip, and annular size in patients with functional mitral regurgitation, pre and post MitraClip. And what you see is in patients with functional mitral regurgitation, after a clip, which is only clipping the tips of the leaflets, or close to the tips of the leaflets, remember, you get a reduction in annular size. The annulus is plastic in these individuals. And more importantly, if you look at those individuals who respond positively with a reduction in the degree of mitral regurgitation, those individuals who respond not only have a decent clipping of the leaflets, but their annular dimensions decrease as well. So reduction of annular dimensions in type 1 MR with MitraClip is important to the mechanism of success. Now finally, I want to just dwell a little bit more on this issue of leaflet plasticity, because this again I think is potentially quite important. You can make complex 3D assessments of the valve. You can also relate the size of the mitral valve leaflet area to various other parameters. So it's recognised that your leaflet area is bigger with increased tenting volume. It relates to ejection fraction. It relates to annulus area. And it relates to left ventricular remodeling. So what this means, there is the capacity, the leaflets increase. If you have functional mitral regurgitation, your mitral valve leaflet area isn't static, it can increase. And if you look at the things that drive this increase, they are essentially the extent of the stress on the leaflets. And I won't dwell on this because it's a fairly complex slide, but what I will do is just to summarize a couple of slides on, and that is that if you look at individuals with functional mitral regurgitation, they have a larger total mitral leaflet area than controls, whether they have mild or moderate to severe regurgitation. These two groups here, with the moderate and with the mild and moderately severe mitral regurgitation, have the same mitral annular size, the same left ventricular dimensions, but the leaflets are not quite as big in those patients with more severe mitral regurgitation. And the rationale behind this is that actually there is more leaflet remodeling here in these individuals than here. Therefore, the degree of mitral regurgitation is less because they have more coaptation. So active leaflet remodeling may be important in terms of the mechanism of MR. And finally, I want to show one more example of a patient. This is loading quite slowly. Okay. So here's an individual with severe type 1 mitral regurgitation. Some of you may have noticed that there is something flapping around up here. You'll see it better on the next slide, on the next couple of loops. Okay. And here it is. And this is a guy with severe dilation of the mitral annulus who's had a mitral valve repair with a ring annuloplasty that has dehisced. And I've absolutely no doubt that in some of these individuals with marked annular dilatation, there is an abnormality of the underlying tissue that predisposes towards this condition. So just to summarize, type 1 MR is related primarily to dilation of the mitral annulus and could be better described, I think, as atrial mitral regurgitation. Atrial fibrillation is an important cause. Maintenance of sinus rhythm is very important in terms of the reduction of the degree, the extent of mitral regurgitation in these individuals. And leaflet remodeling may also be physiologically important. And I'll stop there. Thank you very much.